Hello, this is Lori Shepard. Oh. Hello, this is Lori Shepard. This is your enteral nutrition lecture. So, why might a patient need enteral nutrition? Well, if a patient can't meet their nutritional needs by oral intake, then we have to give enteral nutrition. So it can help meet the needs of someone who just needs to enhance their diet for maybe wound healing, or it can help stimulate someone's appetite, or we have alternative feeding methods. So the GI tract has to be fully functioning for someone to be able to be fed enterally. Otherwise, the nutrition is called parenteral nutrition. Total parenteral nutrition, that's TPN. But we're not talking about that today. We're talking about enteral nutrition. So we're talking about putting a liquid formula into the upper intestinal tract, and it's used in addition to or instead of oral intake for those who need nutritional support. And it is the preferred method, enteral nutrition. And when I mean preferred method, I mean it's preferred to parenteral. There's a lower incidence of sepsis, and it helps maintain the intestinal structure and functioning. But there are risk factors. So when you're giving enteral nutrition, it is preferred to parenteral nutrition. But some of the risk factors that if you're giving enteral formula and it's aspirated into the lungs, then it can lead to an infection, pneumonia, abscess formation, or adult respiratory distress syndrome. And in some cases, if someone aspirates the formula, it can cause death. The high glucose content of enteral formulas provides a medium for bacterial growth. So that's another risk factor, because then patient can get pneumonia or other infection. Other complications can include diarrhea, nausea and vomiting, nasopharyngeal trauma, alterations in drug absorption when you're trying to add medication administration to this regime, and the metabolism of the medication, and various metabolic disturbances. And there's another thing that can happen where the tubing gets hooked up to the IV lines, which then means that you're sending formula into the IV route, and that can automatically kill someone. So a little bit later, we're going to talk about AWARE, A-W-A-R-E, and that's to increase safety with patients that are getting enteral nutrition. So tubes in the stomach. There is the Salem sump tube. This has a lumen for drainage and one to allow for air to enter the stomach. That's usually the blue end, and it's called a pigtail. And then there's Levine tubes that are used for drainage. So the difference between a Salem sump is that you can use it to give a feeding, or you can use it to decompress the stomach. The Levine tube that's used for drainage has a single lumen with holes in the tip and along the side. And so there's a picture in your book. So there's like 4 different pictures, and they're pretty close together. So like I said, other than feeding, you can lavage the stomach with these tubes, collect a specimen of stomach contents for laboratory tests from this tube, or it can be used to prevent nausea. That should say vomiting. and gastric distension postoperatively. The larger bore tubes are polyvinyl chloride, PVC tubes. Salem sump is a lumen for drainage and one to allow for air to enter the stomach through the airport called a pigtail, and it's usually blue. Okay, so a little bit more about the tubes. Selecting a feeding tube. For short-term use, less than 6 weeks, you would use a nasogastric or nasal enteric tube. Remember that the lumen is measured by using the French scale. So the tubes usually run 8 to 12 French and 90 to 108 centimeters long. That's 36 to 43 inches. Each French unit is about 0.33 mm's. A 12 French is about 4 mm's in diameter. So you want to use as small a bore NG tube as possible for a feeding. You can also use nasoenteric tubes. They are longer and they go down into the duodenum or the jejunum. If it goes into the jejunum, it's called an NJ. And then the large bore tubes, Salem sumps, figure 28-4 in your book, occasionally used for feeding, but it should be converted within 2 days to a small bore feeding tube. So we prefer small bore feeding tubes versus large bore feeding tubes. If it's a large bore tube, you would only use it for 2 days. So there's a figure 28-4. A G tube, figure 27-8 and figure 28-7 in your book if you're following along, preferred for long term. They are placed surgically or laparoscopically. So this is your G tube, which is the most common, a J tube, or a G button, which is figure 28-9. The G button is the most comfortable of all for long-term use and for patient comfort. Improved technology has allowed the insertion of PEG tubes and PEJ tubes for even short-term use under very short anesthesia, and these tubes leave less risk for aspiration. The G tube, the J tube, and the G button, there is risk for aspiration, but it's less than with the nasogastric tube. So there's an acronym here for you to know. It's called ALERT. So when you're inserting the tube, you want to use aseptic technique. That means good hand hygiene and clean gloves. You want to label the enteral equipment so that there's no reason that anything should get misconnected. It would be labeled with the patient's name, the formula name, the rate, the date, the time, and the nurse's initials. E, A-L-E, we're on E, elevate head of bed. So it's a minimum of 30 degrees to prevent reflux and aspiration. R, this is alert. R is the right patient, the right formula, and the right tube. We have to match the formula to the doctor's order to make sure it's correct. Sometimes they will add vitamins or minerals that might be a standard formula, but then have that added by the pharmacy. So we have to make sure that it's the correct formula that's hanging. And then T in alert is trace all lines and tubing back to the patient. Trace all lines and tubing back to the patient. So that makes sure that everything's connected and everything's working as it should. Okay, checking for tube placement. In the old days, we used to do an air test where we would instill air into the tube and listen with a stethoscope over the stomach. This method is no longer a recommended method. Also in the old days, we used to put dye in the feeding bags. And so if the patient aspirated, you would see the blue dye come out in the aspirate when you aspirated the stomach contents. So the feeding tube is placed by the doctor. It is placed without direct visualization, and there is a risk of placing the tube into the respiratory tract. So for an NG tube or an NE tube. So it is placed without direct visualization. So you slide it down their nose, down their mouth, and you have the tube. And it has to be secured. So you must check the location of the tip of the feeding tube before each enteral feeding or once per shift for continuous feedings. So the tip of the feeding tube should be in the stomach. So if you mark the tubing where it goes into the nose, and then you measure from the tip of the nose to the length of the tube, and then that should be the daily measurement that you're taking to make sure that there isn't more of the tube that's sticking out than should be, because then that means that it migrated up the system and potentially could cause risk for aspiration. So you have to check each and every time. Failure to verify placement could be disastrous because it may result in infusion of the formula right down into the lungs. So every NG or NE tube is radiographically X-ray verification. It's the most reliable method for confirming tube placement and must be performed before the first feeding. So that means that the tube has to be X-rayed, and then it's charted in the chart where the tube is. No bedside method alone is reliable that verifies tube placement, but we do these methods in combination with each other. So X-ray is not practical for ongoing verification, but the tube can move upward. So bedside methods, we're going to be talking about in just a little bit. But as an introduction, we aspirate stomach contents and we look at them to see what color they are and how much, and we also check the pH. And then in combination with a few other methods that we're going to talk about in just a little bit, if in doubt that the tube has migrated, then you must re-X-ray the patient before you would resume any feedings. So next we're going to talk about we're going to skip ahead a slide. Okay, we're going to talk about continuous feedings. So your feeding is probably something that is prepared commercially and comes in a plastic container, or it could come in cans that you place into a plastic container. So one is pre-sealed and one is something that you're mixing where there's more potential for contamination. So you most commonly use commercially prepared products. So continuous feedings are feedings that are constantly flowing into the patient, evenly distribution of nutrition over 24 hours. This better helps control blood glucose levels. And this could go via the NG, the NJ, the PEG, the PEJ, the G buttons. It's to patients who require intensive nutritional support. Gravity feedings are feedings that are not precise. The gravity feedings increase the risk for reflux, diarrhea, and aspiration. Gravity feeding is a pump-controlled infusion. Nope, that's not correct. Continuous feedings are on the pump. Gravity feedings are ones that you just hold up and give the formula over gravity. And then you can interrupt that for meds or for flushes of water. But if it's continuous, then you have to actually stop it and give the meds and give additional water. So this is just talking about feeding schedules. It might be continuous, it might be gravity, it might be a cyclic feeding. Those are feedings that occur less than 24 hours per day. It's more physiologically situated to the patient. Nocturnal feedings are a form of cyclic where the patient's able to eat his meals during the day and you give an infusion of the formula at night while the patient's at rest. 24-hour infusions are infusions, another variant of cyclic, where there's a 4-hour break. So you would set the machine to only run for 20 hours, and then it would be off for 4 hours. And that's where the patient could get meds, they could get their AM care done. Intermittent feedings are feedings that supplement oral intake, usually given over 30 to 60 minutes. And so that would be an amount 250 to 500 milliliters every 4 to 6 hours. And then the bolus method, sometimes used for intermittent. It can be syringe delivered by gravity, 300 to 400 milliliters via the tube over 5 to 10 minute period. It's the easiest method to teach family members. This method is at increased risk for respiratory aspiration and stomach distension. You would only use the bolus method with a gastric tube, never with an intestinal tube. Okay, before I go forward, some of the adverse effects. This is discussed in Lilly. GI intolerance to the formula can cause diarrhea. Rapid feedings can cause dumping syndrome, aspiration pneumonia, alterations in mental status, gag reflex, or general mobility issues increase the adverse effects. So someone that's not really conscious and doesn't have a gag reflex, if they're getting feedings, they're very, very at risk. Some of the interactions that the feeding does interact with any medications the patient's getting, and they can have significant food to drug interactions. And one medication in particular, that medication is phenytoin or Dilantin. The feeding the feeding formula decreases the absorption of the phenytoin. So that means the patient's not getting the medication that they need, and that can result in seizures. Holding the feeding for 2 hours after you give phenytoin would be recommended. So you have to follow your hospital policy and protocol. So open and closed feeding systems. That was what I was talking about with whether you have something that comes up in a bag from the dietary kitchen or something that comes up in cans or in a pre-filled plastic container. So an open system is something that is open and exposed to the environment. So this would be opening cans of formula and using a syringe to let the formula go in by gravity. Or you can pour it into a bag and give it as a continuous or intermittent feeding. You have to flush and clean the tubing after each delivery, and the feeding should hang no more than 4 hours. If you have a closed system, it is a pre-filled system where you get a bag or a bottle, and this functions like an IV fluid. So you have to spike into the system. The tubing attaches to the feeding pump, and it runs via a manually controlled drip chamber. So the pumps, and you can probably find an example of a pump if you look up YouTube and you look up a kangaroo pump. That would be an example of a feeding pump. The tubing is called, made by the manufacturer, I think, Kangaroo, and it's a way to feed the patient, and it can safely hang for 28 to 48 hours if you use strict sterile technique. So, what we've been talking about is the tubes, and now we're going to talk about, and we talked about how you can send the formula through the tubes, but what is actually included in the formula. So a basic formula is 12 to 20% kcals of protein, 45 to 60% kcal carbohydrates, 30 to 40% kcal fats, and then additional vitamins and minerals. It's usually lactose free. There's complex carbohydrates, fats, proteins, and it does require that the patient has active digestion and absorption. And if you look on box 28-6, you will find further explanation. So the basic feeding formula has no significant nutritional deficits, and it's 1 kcal per milliliter. So if you're trying to figure out how many kilocalories are in the can, you just multiply 1 times how many milliliters are in the can, and that tells you how many kilocalories total are in the formula. High protein formulas are for individuals who have a substantial need for protein. So those that have burns, open wounds, malnutrition. Elemental formulas do not contain complex proteins. Instead, there's amino acids, peptides. It is used for those with severe small bowel absorption dysfunction. It's fiber-free, it's highly osmotic, and the use is controversial. Diabetic formulas for type 1 or type 2 diabetes has controlled carbohydrate intake. So it would be a consistent carbohydrate, which is the recommendation for the oral intake of a diabetic, consistent carbs. Renal formula, that would be given to a patient that has renal failure or renal insufficiency. The renal formulas limit sodium, potassium, and nitrogen intake. Pulmonary formulas are those that provide 55% of the calories as fat so that less CO2 is produced per unit. So this is someone that has lung disease, as the name pulmonary formula steers you to lung disease. Fiber-containing formulas. So if it has fiber, then the potential protective effect. So the fiber is keeping the person from becoming constipated. So in a long-term care setting, if you just gave a basic formula, the patient might not be getting enough total. They may get the kcals, but they may not be getting enough water and liquid intake. So you have to look at that, and the doctor may order flushes of anywhere from 50 to 100 milliliters every 4 to 6 hours. So fiber-containing formulas, those that are in long-term care that require enteral feedings over a prolonged period of time, those individuals would likely be getting a formula that had fiber. Okay, monitoring a patient. So when we talk about monitoring a patient, we're talking about checking the tube placement, checking the skin condition around the insertion site, checking laboratory values. So that would be glucose, BUN, and electrolytes. Checking residual. How much might the person be digesting and how much might be undigested? And that undigested amount is called residual. And that residual can increase the risk for aspiration. So we want to make sure that our patient isn't holding on to the formula and that it's going through the digestive tract. So we check the GI status. And all of this helps to allow us to detect any complications that can affect metabolism or fluid balance and to assess the response of the patient to the enteral feeding. So when they first start the feedings, they may start it at a very low rate per hour, and then they may say if the patient's tolerating that, then you can increase it by so many milliliters per hour. And if the patient's not having residual, then you may be able to up the infusion rate. But that's based on what the doctor orders. The feedings may need to be increased or decreased depending on the patient's clinical condition. And this you can find on page 982, Clinical Insight 28-5. So the position of the feeding tube. Remember I talked about there should be a mark where it goes into the patient's nose. And that mark should always be looked at to make sure that it remains right outside the patient's nose. And then taking a measurement from that mark to the very end of the tubing. That doesn't mean the end that goes into the patient, the end that stays outside of the patient. And that number should be a consistent number. We want to make sure that it's secured to the nose, and so that means that the tube is going to be in the nares, and it may be going into the stomach or into the duodenum, and it needs to be secured so that it doesn't move around. And there's usually a special securing device that they have at the hospital. Gastrostomy tube, PEG or PEJ insertion site. If there's any erythema or drainage around that site, it should be reported. It should be cleaned with soap and water daily. No dressing, because that dressing just holds moisture and a medium for bacterial growth to occur. So if you see any pus or blood around that insertion site, then the doctor needs to be aware. Fluid balance. It's very important with people that are on enteral feedings that we keep intake and output, and that the patient is on daily weights. So we want to look at that intake and output, and we want to make sure that it balances. We're not giving too much to the patient. So giving too much, how might that patient present? That patient's going to present with possible pulmonary side effects. So having crackles, having rhonchi. If your respiratory assessment finds fluid in the lungs, then that may mean that the patient is experiencing fluid overload. Weight can also tell us if the patient may have too much fluid on board. And we're going to check the hospital policy, and we're going to check a residual volume on the tube before we give a feeding or medications. So we want a quantity that is equal to or greater than the flow rate in 1 hour, or 150 milliliters or less. And we want to draw that from the patient to make sure that that's what the true residual is, and then we usually instill that residual back into the patient by gravity. So 150 milliliters or more of residual is concerning, and we may need to stop the feeding, or we may need to decrease the feeding per the doctor's order. So we have to notify the doctor that there's excess residual volume and to find out what he wants us to do. Frequency of bowel movements. So we want to avoid constipation in our patient. So that may mean that the doctor is going to add water flushes, a formula with fiber. If your patient is having diarrhea, that could indicate that the patient's not tolerating the type of formula or the rate of administration of the formula. Just before giving a feeding, or every 4 to 8 hours for someone that's on a continuous feed, you would check bowel sounds. And that's part of your assessment, but you're going to do that more often when your patient has a feeding tube. Peristalsis must be present. Otherwise, your patient should be NPO. Abdominal distension. Well, if the patient's retaining the amount of formula and it's not being digested properly, then the patient may become very distended. So daily abdominal girths may be something to consider, and that usually is a measurement with a tape measure that's taken at the umbilicus, and it's charted every day. Serum electrolyte levels may be taken, and urine for sugar and acetone on your diabetic patients. Skin turgor, hematocrit, and urine-specific gravity to check for dehydration or overhydration. And a serum BUN, BUN, and sodium levels. And that's especially important if your patient is on a high-protein type formula. Preventing contamination of enteral feedings. The enteral feeding provides an ideal medium for bacterial growth. So we have to take certain precautions to prevent our patient from getting contaminated feeding. So the way that we handle ourselves and the preparation of the formula is very important. So first, you would check the dates on the feeding, on the can, on the bottle. We don't want to use anything that is expired. We want to put the date on the tubing, to make sure that the person knows how long that tubing has been hanging, because that tubing will be changed when the formula changes or the time frame changes. So label feeding containers with the patient's name and date and time hung. Document the time in the patient record. Use meticulous hand hygiene and wear non-sterile gloves. Use sterile equipment and supplies. Once you have opened them, handle them as little as possible. So you shouldn't be taking your time. You should be focused on what you're doing and get the formula into the container with as little possibility of contamination to the outside air as possible. Handle them as little as possible. Disposable feeding equipment. So that is what it says, disposable. So that means you can only use it one time. So no one should be washing and reusing feeding tubing or containers. Replace feeding equipment after 24 hours, or according to hospital policy, replace the feeding tube according to the manufacturer's recommendation or agency policy if that's sooner. So they're not going to take the NG tube or the small bore feeding tube. Okay, I got to figure out how to stop this. Charlie! I don't know how to stop it. So then will it pick up where I left off?
It's still recording. Why are you